Hello from sunny Kos, second day of the Mediterranean Emergency Medicine Congress. Today we have many more workshops and the Hippocratic Oath, which will take place in the oldest hospital in the world, the Asclepeion. Enjoy.
I directed a course here at the conference with the assistance of a couple international colleagues, and it dealt with regional nerve blocks. These are blocks that we as emergency physicians can use in the treatment of different patients. They provide pain relief. They also allow us to use less lidocaine and avoid infiltrating the wound margins. Infiltrating the wound margin with anesthesia or with anesthetic causes tissue distortion, which makes a cosmetic closure much harder to achieve. A block that I'm using more and more frequently in my daily practice is the femoral nerve block, which provides excellent anesthesia to the hip. We see a lot of hip fractures with an aging population in the U.S. as well as elsewhere in the world. I do find as I travel around and teach different programs and different conferences that regional anesthesia is not used frequently enough. There are three nerves that provide most of the sensation to the face: the supraorbital, infraorbital, and the mental nerve. The three exit the skull in a line formed by the pupil and the corner of the mouth. This is very consistent between patients and it's constant, and it makes it easy to identify. A person with a forehead laceration, I can do a supraorbital nerve block. I line up the pupil, the corner of the mouth, right above it. I can feel the supraorbital notch and go in there, deposit 1 to 2 cc's of anesthetic. There's a second nerve that innervates the forehead called the supratrochlear, which exits slightly medial, so I can go across the eyebrow towards the root of the nose, deposit a wheel of medication, and that will provide me with anesthesia in this area in the forehead. For lacerations and injuries on the cheek, we can use the infraorbital nerve, which exits in line with the pupil in the corner of the mouth, approximately 1.5 to 2 centimeters below the orbital margin. One can do transcutaneous blocking, or one can go through the mouth up inside and deposit again 1 to 2 cc's of medication right above the infraorbital foramen, and we'll get anesthesia in this area and the top portion of the lip. For lacerations on the lower lip as well as the chin, the mental nerve can be numbed, again from the outside or from inside the mouth, and provide very good anesthesia.
Ultrasound is a great tool for medicine, and especially for emergency medicine. Unfortunately, not everybody has the luxury to be trained adequately in ultrasound, either because we don't have the ultrasound machine or because we don't have too many patients. So, how is this solved? How is this problem solved? Easily.
Hi, this is our ultrasound simulators. This is like 60 patients in one, because for now on this mannequin you can just do the TTE, the TEE, and the fast exam as well. So I'm just gonna show you quickly the fast exam. Just by going here, you can just put your probe, and just by doing a little movement, you can just make your organ appear and disappear, just to be sure that you don't have free fluid around your kidney. The second positioning, it's on the xiphoid, so you just have to put your probe just to have your cardiac feature. Make sure that you don't have any tamponade. Make a little swipe just to be sure that you don't miss any free fluid. The third positioning, it's on the left side of the patient. It's approximately like maybe 2 ribs up to the right side. Again, you will just be able to have your left kidney, just to be sure that you don't have any free fluid between your left kidney and your spleen. The last position, it's on the pelvis, so just to be sure that you don't have any free fluid around the bladder. So you just put the probe near the pelvis bone, and you just make sure that you don't have any free fluid. So you can see here that you have the bladder, and you can see here that you have free fluid. So because the bladder is full of liquid, you will just see the black liquid here, the wall of the bladder, and you can see that you have another amount of liquid. So you can just say that this is abnormal one. So that will be a patient with free fluid in the Douglas patch. You will be able just to see the swinging heart here and the atrium just collapse. So when you have that kind of patient, you have to do something really, really quick. You can see here between the spleen and the kidney, usually like both structure are just together, but here you can see that you have like a little black amount of liquid over there. So at this time you can just say that there's free fluid in the spleenal renal reflection. Here you can see that you have your liver over there and you have your right kidney, and again you can just see that there's something wrong over there because you have like a black amount of liquid between the two organs.
So having such a great teacher as Melanie, I guess I'm proficient now in doing my own echoes. Melanie, what do you think?
Okay, so just go like this a little bit and just go a little bit more on the right shoulder and you will be able just to see your fourth chamber. So you can see your atrium and your ventricle and you will be able just to make your heart disappear.
All right. So how much training does this require for novice?
I think like maybe just one time on the normal, and after if they can just practice to on each pathology like twice, they will just be able to go on the real patient and just be comfortable.
Okay, thank you. This is not a real pro, right?
No, this is not a real problem.
My passion is ultrasound, and we've been running these courses for the last 10 years all over the world. Our focus over the last 5 years has been to travel to third world countries and teach the local doctors more and more ultrasound skills and help them in acquiring refurbished second-hand machines so that in remote villages, mothers with bleeding can have access to an investigation where previously they had nothing. There isn't anything that I've learned since I left medical school, which has been as useful in my day-to-day practice as ultrasound. Common condition, like an aortic aneurysm. A big study showed that the time to diagnosis without ultrasound was about 70 minutes, whereas time with ultrasound is 12 minutes. Mannequin training is an extremely useful tool that we have at our disposal now because it allows us to monitor our trainees remotely. We can't be at the bedside all the time watching our trainees scan, but on the mannequins they can do their scans and record the scans and email them to us so we can critique them on what they're doing well and what they're doing badly and what areas need development. Yes, Big Brother's watching. Thank you. Cheers. Thanks. Thank you.
We basically did a 4-hour workshop where we were able to develop and review some of the ways to make a good curriculum and make a good scenario for simulation, and then talk about debriefing and actually split into small groups where we would help the students debrief and become better debriefers overall. We made a scenario that we wanted to talk about, and that was basically an asthmatic. Goals and objectives were to demonstrate good clinical management for dyspnea, as well as be able to have good communication skills with our team, but also to the family members that were there. Afterwards, we split up into small groups, 4 each, and then each student was either the role of the doctor, the nurse, or the debriefer. I think it's a good way to learn because it's hands-on, it's real time. I think it's just one more tool for education to use.
Doctor, I just brought this guy in. He's 17. I got called for shortness of breath. I showed up to his house. He was like leaning over and breathing really hard. He sounded kind of wheezy, so I put oxygen on him and brought him in, and his dad here came with him.
Okay. He's been really short of breath. Anything else? Do we know his past medical history?
Asthma, I think.
Okay,
yeah,
thank you.
He does have asthma.
Hey, can you tell me your name?
Joe, I'm really short of breath. Help me, help.
Joe? Okay, this patient does not look good. We need a nurse to come in here.
Yeah, he just came on break. What's going on? Yeah, he looks bad. I'm hearing wheezing bilaterally. Kevin, where's your IV?
Nebulizer, neb going.
Let's get a chest x-ray. I don't think he's breathing.
You gotta intubate him, don't just stand there.
I see the cord. I'm passing the tube through the cord. Tube is in.
Go ahead and ventilate for me. How deep is your tube? I'm not hearing anything on the left side. It looks like crap, we gotta do faster, faster.
Passing the tube through the cord.
I'm still not hearing breath sounds. Are you sure you're not in too deep again?
I'm not.
Radiology calling for the ER.
Doctor, I think you need... Hi, it's ER Doc, I'm busy. What's going on?
He's got a left tension pneumothorax.
He's got a tension pneumo. Decompress him. Keep ventilating. Okay, I've got breath sounds on the left now. Just recycling right now. Stats are going up.
This concludes your case.
I have to thank the Heart Foundation for this award on behalf of my colleagues that worked on this problem.
Istina